to implant a pacemaker, considerations for setting up device implantation in a leach source core environment. And there are definitely, reasons why we want to do this. First of all, we have the patients who need devices, and pacemakers. There are only a few emergencies, I would say, that an electrophysiologist has to deal with. Actually, there's truly only one emergency that you really have to come into the hospital for, and that is sudden loss of conduction leading to heart block. And so either yourself or interventional cardiology has to put in a pacemaker. Otherwise, they would have to, otherwise they would basically put in a temporary pacemaker when they come into the cath lab, or they would, this is one of those procedures that's emergent. It's our, I guess, our version of a STEMI, and we take this very seriously. And so I'm going to start off with a case. So let's say we have this 35-year-old woman, and she has no significant past medical history. She has feelings of fatigue and decreased energy for the past few years, and she was finally advised to come to the doctor. And then this is her EKG, right? So I want you to kind of take a look at it and look at it really closely. And
did you want them to post in the chat what they think might be going on here?
Well, not yet. I'm trying to see. Let me see if I can do this. All right. Well, somebody has already said, complete heart block. So pretty much I said, okay, what is your diagnosis? So if you can post in the chat right now what you think it is. I have Olatima who said complete heart block, and if you read, somebody says third degree AV block, yes or no?
So I can see here's some 2 to 1 as well, some folks are saying. Dr. Caro, do you mind pulling the EKG back up? Seeing some high-grade AV block. That's a safe one there.
Okay. So high-grade AV block, third degree with a junctional escape, complete heart block, 2 to 1. So this would be a complete heart block. And the reason how you can tell it's complete heart block is, so you have first degree AV block where you're talking about atrioventricular block. So you have first degree AV block, you have second degree AV block, and then of course you have third degree or complete heart block. Your first degree and your third degree will always give you an R wave that is regular. So the first degree AV block, it'll give you a regular R wave because it's just describing, delay in AV conduction, right? So the distance from the P wave to the QRS will always be the same, right? So it will always give you that regular QRS. The other thing that gives you a regular QRS is a third degree AV block. And so if you look at the EKG, before you start looking at the P waves and the QRSs and trying to figure out what the relationship is, if your impression is that the R waves are uniform, or the R waves are equidistant from each other, then that is more likely to be a third degree AV block than not. Now, of course, there's a 2 to 1 AV block that could satisfy that, but in 2 to 1 AV block, you would expect to see that the distance between your P wave and your QRS should always be the same. And in this particular situation, you see that they are working irrespective of each other. So therefore, this would be a complete heart block. So that's really good. Now, what would you do in this particular patient? Would you observe the patient, do a treadmill stress test? Would you place a pacemaker? Or would you do an echo because you need more information. So if you can put your answer in the chat. So I see a lot of C's, C, C, C's, C, C. Echo. So some people are saying D. Okay, echocardiogram. And can somebody say, for those who said that they wanted an echo, could they say why they wanted an echo? Because they need further information. Okay, what kind of further information would you be looking for? Anybody want to answer that question? So you can think about it and put it in the chat as we go further. So pacemaker implantation, like I mentioned, really important when we talk about life-saving cardiac care. When we are considering placement of a pacemaker, first of all, you have to have a patient that's indicated for, a pacemaker placement as a result of symptomatic bradycardia. Going back to the chat, somebody said an echo to rule out infection as a cause of heart block. Another person said searching for any possibility of ischemia or valvular disease. And somebody else said, okay, to know other causes, whether they are transient. So we'll come back to that question towards the end when we're discussing the patient. Now, when we're talking about considerations, for pacemaker implantation, it's not just simple as, okay, you have a patient, maybe somebody brings you a pacemaker and they say, okay, we're cool, we're just going to put it in. It's technically easy procedure, but you have to be trained. And if you're not trained, then you could have complications, and it's a little bit more challenging than you would like it to be. And so, the different things that you have to have in place, you have to have a procedural area, right? And this procedural area has to be equipped with the necessary tools. Like some of you heard Dr. Adafet speak on, earlier when we were talking, you have to have the right tools, because if you don't have the right tools, then what is a very simple procedure ends up becoming really complex. The other things that you have to have procedural expertise, both on the level of the physicians who are involved in the case, as well as on the level of the catheterization lab staff or the OR lab staff. For the physicians, you have to have a well-trained interventional or invasive cardiologist who is able to put in a pacemaker. And then you also have to have training with regards to the referring physician, right? Because for you to be able to send a patient to get a pacemaker placed, you should have a referring physician who knows what it is that they're looking for. Because a lot of these patients, particularly if they're young enough, they come in with very non-specific symptoms. They might come in saying, oh, I feel tired, I feel fatigued. There's some people who will be like, oh, you're just lazy, you're not doing what you need to do, but not knowing that there's a medical reason for this. And so you have to have a relatively high index for suspicion for diagnosing the patient who would need a pacemaker. The second thing is, looking at once you have figured out how to do it and you're going to place the pacemaker, then, you have to have well-trained pacemaker cath lab staff. So your nurses, your x-ray techs, and a physiologist who's able to help you with the pacer. You definitely want to make sure that you have all those staff well trained so that you can have an excellent program. So let's see, somebody was raising their hand. Josephine Rogat, did you have a question or a comment? Okay. All right, so I will ask you to unmute if you feel like you wanted to speak, then you could do so. And then, so going back to the presentation, of course, you would want to have, your patient identified so that you could place your device. So starting with cath lab is not really an easy feat this was from a paper that was written in 2019, talking about the number of cath labs in Africa. It's not a really comprehensive list, but it basically does kind of tell us, okay, exactly what's going on in the different countries, as well as, the different, countries in sub-Saharan Africa. And, they put a rough estimate of labs in sub-Saharan Africa. I think these numbers are not really up to date, just because I know in Nigeria we have more than 6 now. But this was, like I said, published in about 2019, and I think with data from 2017. But as you can see, the number of cath labs that are capable of doing pacemakers, not really that much, right? So you have some, West Africa is like, empty. East Africa, a little bit empty there. Central Africa, I mean, there's nothing there. And then you have more in South Africa where you see a lot. Oh, what did you say then? Okay. So, basically, when we, Bonnie et al. In 2017 kind of came up with this, paper where they had done a survey of different centers in Africa, trying to ask them, hey, what are you able to do, and what is the electrophysiology capabilities in Africa as a whole? And what they were able to find is that in the countries that have the bright green, did have proper pacing activity, but basically if you can look over here and you look down there, you really can't see, like if you look here and you look there, you really can't see a lot of pacing capabilities there, which is a little bit concerning. And when you look at the numbers really tell us, okay, that there is a lot of work to be done. Pacemaker implanting rate per million of the population is basically in 2014, the last time was 0.12. So less than one pacemaker per million of the population was placed in Nigeria. Above 1, 2 in Benin Republic, 3 in Kenya, 11 in Senegal, so I guess they're doing great. In South Africa, 114, in Tunisia, 201, and Mauritius is 239. So all of these numbers, you might think, okay, well, at least here they're 239, that's great. But really, it's not really that great, because when you compare that to the Western world, the numbers are really much higher. So in the same paper that was written by Bonnie, they talked about pacemaker implantation rate of countries in Africa when compared to Europe. And if you look at Germany, it was 1,152 per million. And in, Africa, we're less than 1,000. So that is definitely, something that we need to consider. And it's not because we don't have the patient population that can accommodate this very important life-saving therapy. Now, there have been a few advances that have made their way over the last few years. The first thing was the provision of re-sterilized and repurposed devices for use in pacemaker implantation. They had just finished enrolling patients in the My Heart, Your Heart trial. Hopefully those results will come out in the next year or so, and that will give us a lot more information about the safety and efficacy of this practice for patients who are not able to afford new devices. And this could open up, a whole, world of patients, or a whole world of opportunities for patients to be able to get their life-saving devices.
Okay.
Now, when we start thinking about placement of the device or placement of the pacemaker, a lot of us who do it, particularly in the Western world, we're used to coming into a room like this, where you have a cath lab with, the C-arm that's pretty stationary, but has a lot of power in the fluoroscopy. You have your table, and you have this big room with your anesthesia machine, etc. But sometimes, it's not, you're not able to provide that, because all of this is really expensive. Not that there isn't some, right? So in Nigeria, this is the cath lab at Lesotho, and as you can see, they do have a C-arm, and they have, a lot of trained staff able to do these cases. This is the cath lab in Abuja, basically able to do the same thing. That's Dr. Dafide doing his case, which is really exciting. But the other thing to consider is maybe you don't have to use a fluoroscopy suite, and maybe you can just use a C-arm. And for those of us who work in a hospital, you know that a lot of hospitals at least have a C-arm, where they do cases with ortho sometimes they do cases with neuro. And so, you can also use this for placement of the pacemaker, just because a pacemaker placement doesn't really need that much temporal resolution in placement. So what would you need as tools as at a minimum? And of course, when I'm saying that you're trying to develop a program, you're not doing this in isolation, right? You're doing this with other things happening. You're looking at the training of, the physician. You're looking at providing the room with the tools that you need. And then you're also looking at training your referral physicians or patients so that by the time all of these three things come together, you can have a very successful program. So when you're looking at your room, you have to have an OR room. You have to have a room where everything is sterile, because this has to be a sterile procedure. You are placing a device with leads that go into the heart, and that can be a high source of infection if care is not taken. So therefore, an OR room is essential, or at least the sterile room is essential. The C-arm is very essential here. Until they produce, leads that are able to be placed through ultrasound, you really do need the C-arm for correct placement of your device. You need visualization all the way from where you make your pocket, which typically is in the left subclavian area, all the way down into your heart. And so the C-arm definitely does give us that, visualization that we need. Of course, we need a bed that is able to allow the C-arm or the X-ray to visualize through. You need a table where you're going to place all your implements, and I'll show you an example of what that looks like. You need an external defibrillator just in case, because sometimes, in placement of your device, sometimes you might actually lose you might lose native conduction, and so you might need external pacing, so an external defibrillator is necessary. Of course, you need an EKG machine, because if you don't have one, you're not going to be able to know what's happening with the patient. So if the patient loses conduction, you won't be able to see that. So you need that continuous EKG monitoring. Antibiotics, definite. So before we do the case, we usually will start the patient on antibiotics, and actually that is standard, that within 2 hours of devices, patient incision, you have to have antibiotics completed. Anesthetics, very important. We use local anesthesia, so lidocaine is your friend. And in addition to that, it's also helpful if you use some anesthetics and analgesia as well. And so I typically will use fentanyl and Versed to just basically make the patient a little bit more comfortable. This bed is very uncomfortable for the patient, and the procedure lasts anywhere from 45 minutes to an hour and a half, depending on the type of device that you're placing. Sometimes it can be longer than that. There was once I was trying to place a CRT, and that took about 3 hours. So it can become very uncomfortable for the patient, and the patient might start moving around if we don't give enough pain medication. Of course, you need protective lead shielding. So the physicians, the staff have to be wearing their lead to protect them from the X-ray that is brought out by the C-arm. And then, of course, you'll need your sutures, sterile drapes, C-arm cover, and a backup power source for your C-arm and for everything that you're using in the procedure.
I'm not sure, sir. Yeah.
Oops. Now, but you see arm versus the cath lab, what do you have to consider when you're trying to figure out whether you're doing a C-arm versus going to go straight for a cath lab? Well, the cath lab does give you a lot more flexibility. you're able to do a little bit more. You're able to, do, in addition to doing, pacemaker placement, sometimes you're able to do CRT placement, which needs that kind of more discrete visualization of wires that you might not be able to see with a C-arm. The C-arm doesn't have as much resolution. It's definitely much more powerful. There are more post-processing options. You can, look at things, zoom in, zoom out, basically play things, keep things on review so that you can kind of see where you've been and see where you're going. It does allow you to also do coronary interventions, which you cannot quite do on a C-arm, right? Versus the C-arm. Now, why would you consider using a C-arm versus a cath lab? Well, the C-arm does allow you to start up a procedure lab less expensively. So whereas a cath lab, it can go anywhere from, in dollars, $300,000 to $800,000 for a cath lab, a C-arm costs typically about $18,000 to $25,000. So as you can see, it is, orders of magnitude less expensive than a cath lab. It is definitely less powerful. So the highest you can see is about 25 kilowatts, and it does not give you that resolution. It's enough for a pacemaker, but it's not exactly enough for something that is a little bit more, needs a little bit more finesse, a little bit more resolution. Another good thing is that it's mobile, so you can use it if you have multiple OR rooms. You can take it from one room to the other and not have to worry about, breaking it or spoiling it. And it doesn't require any fixed lead shielding, also because it doesn't have that much power. It doesn't produce that much X-rays, and so that would be definitely something to consider. Now, with your implantables and tools, when you're placing your pacemaker, the procedure itself, we've talked about this before. If you go on our YouTube channel, there are definitely a couple of presentations where we talked about, actual placement of a pacemaker. If you're running through it very simply, you make a small incision underneath the clavicle, you access your vein using a Seldinger technique, put a couple of wires down, and then you're able to put a sheath. I like using the sheaths that have the hemostatic valve there, where you don't have blood flow back. But of course, those are more expensive than the ones that allow blood flow back. And of course, those sheaths are typically slittable, so that you can keep your lead in while you take the sheath off. And then you put your wires through, make your pocket. And for you to do all of that, and to do all of that with good speed and with good tools, you have to have at the very least these implantables and tools. So that includes your scalpel, of course, for you to make that initial incision, scissors for you to be able to dissect to make your pocket, retractors so that you're able to basically see into the pocket. I typically will use Wheatlanders for this. You definitely need a lot of bowls and towels so that you can keep everything where it needs to be. Your programmer and wands are needed so that you can tell what's happening once you place your lead, because you have to be able to tell what's happening, whether you have good contact, whether you're in a very stable position. Your PSA and PSA cable adapter, the PSA is your programmer, and it will help you figure out where you are and also test lead placement. The device, which is the pacemaker generator, that is typically the most expensive part of all of this. Like I said, this has been a rate limiting step, getting a pacemaker generator. Typically, you would have to buy it, which can cost anywhere from $700 to $1,500. So you convert that to your local currency at will. Your pacing leads, of course, very important. Hex wrench, PSA cables, your lead introducers, like I mentioned, and then of course a syringe and needle for you to be able to make that access to your veins. This is what I typically like my table to look like. Of course, this really depends on what you have available. For me, this is a 6-foot table. You can see where the tools are sitting over there, and this is how I like to place out I like to place out my tools. I'm a little bit, I guess, picky about how I place things. And so, but this is typically how I like my table set up. Um, Usually, though, folks kind of place it wherever they want, and it's typically as you would like it. And of course, it would be nice if we had a cath lab, a live 12 lead. The live 12 lead is essentially, especially important for patients who you're going to do a left bundle placement. If you have temporary pacing equipment, for those patients who have complete heart block, you might get into the ventricle and immediately lose your native conduction. And so temporary pacing equipment is very essential. Your lead stylets are typically in with the lead that you're actually placing with. So those are actually supplied for you. Suture sleeves are also actually supplied for you. Micropuncture, basically if you have some anxiety about your access, you can definitely use a micropuncture needle. And of course, liking to see is very important. And so if you can have surgical lamps, that would be great. Defibrillation pads and cautery is also really important. To the defib pads you place on the pacer, so that you place on the pacer on the patient so that you can pace the patient if needed. So with regards to training of your proceduralists, they go through a long slog of training, right? So after medical school, after doing your housemanship, if you, like in Nigeria, you have to do your youth service, you go through that. Then you start off doing your general and internal medicine or pediatrics, if you will. And then after that, you have to do some more training in cardiology. And typically that can take anywhere from 6 to 8 years, really depending on your country. After that, you go on and do what we, suggest that you do is an interventional cardiology year where you are able to get a huge volume of invasive procedures under your belt, because those are the tools and those are the skills that you're going to use, and those translate very well into training for pacemaking. When you're trying to get access, for a coronary intervention, for instance, even though you're going into the artery, that, comfort level in, getting access will serve you well in doing a pacemaker implantation, where this time you're going into the vein that sits on top of the lung, right? And so one of the complications that we think about when we're doing that is, pneumothorax, and you don't want to have, too much of those. So, having some sort of interventional training is always very helpful. Or, in my case, I didn't do interventional training, I went straight to EP, but that's that capability, I can do that because, I have a job basically doing electrophysiology. Is not always able to, or you're not always able to in different countries. And so, your chance to get that skill set probably is very necessary. It's only able to be done by doing an interventional cardiology here. Now, on the flip side, for the physicians who are going to be referring the patients, what we need is a recognition of abnormal physical exam findings. You need to know that you will be able to recognize when an EKG is abnormal, and also that you have the resources to obtain EKGs in resource-limited settings. And so an EKG machine can be very expensive. In my practice, it can go anywhere from about $500 to about $3,000, $4,000, depending on how fancy you want it to be, and if you want it to have AI that interprets the device of the lead capture for you, and also if you want it to just give you PDFs, et cetera. However, if you are just doing, a simple EKG, sometimes you can get some as low as, a little bit less than $500. But if you don't have that, I'm sure all of you know about, the Cardia device. Sometimes you can have if you have your Apple Watch, that can give you different strips. And this is an example of a patient who had, an AV block that was detected by his Apple Watch, and you can see kind of like the P waves like here and here. So basically, some sort of like 2-to-1 AV block that was diagnosed, by the patient's Apple Watch. So you can kind of see here that it's basically, you can see at the end of the strip where he resumes his normal conduction, but prior to that, he was 2-to-1. There was a third syncopal episode, again 2-to-1, and this is the EKG strip afterwards. And then when the patient came into the emergency room, you could tell that they had some heart block. So this was, a paper that was written that basically showed how also cardia can be used in this particular case. Sometimes you can have increased sensitivity if you place the cardia in 3 different places. So for instance, in this particular spot, you had, A, which is lead 1, which is basically your left and right, fingers, right? And that would give you lead 1. This will give you lead 2. So if you put it, one of them from your right arm to your left leg, and then if you go over here and for lead 3, for your precordial leads, you just put it across your chest. And then you're able to see the heart in 3 different directions. So this is kind of a poor man's EKG. This one was just demonstrating that they were able to see some ST changes that were worrisome for, and later on when they got an EKG, they were able to find out that the patient actually had a STEMI. And so that was what they used to treat the patient. And so, maybe there are some cheaper options to getting a full-on EKG machine. For instance, the cardiac costs about $100, and it's definitely something that can be used, in a resource-poor environment, because you really don't need that much. You just need a phone and the cardio device. So that would be really good. Now, there have been papers that kind of looked at the diagnostic accuracy, and even though this paper, concluded that the smart technology is promising, but it's not really, up to the level of an EKG machine, it does still kind of beg the question that, hey, possibly we could use this in a resource-poor setting. Now, going on to kind of patient selection, how do we figure out the patients that would need a pacemaker? So the patients definitely have to have symptomatic bradycardia. And then you have to look at the locations of block. So you can have different locations. You could have the location of block being in the sinus node, or it could be in the AV node. And each of those have different implications for whether they need, a pacemaker or not. And the other thing that you want to look at is considerations for accompanying conditions. Do they have heart failure? Have they had an infection? Are there some medications that might be causing their symptoms? These are things that you want to look at first before saying, hey, this person definitely needs a pacemaker. So for the levels of block, I think we've already talked about this as well. I gave a lecture last year that should be up talking about, levels of block in the sinus node and the AV node. But as a brief, kind of run through, you have your sinoatrial conduction as well as your atrioventricular conduction. In the AV node, it's divided into suprahischian, intrahischian, and infrahischian. Intrahischian is not really, you really need EP studies to figure that out. But suprahischian is basically in the AV node itself. Infrahischian is in the bundle branches. With the node, the lower the level of block, the higher the acuity of what you need to do for the patient. So for a sinus node arrest, it's basically a sinus pause. It has to be, a PP interval that's greater than 3 seconds, and is considered to be abnormal. Now, if the patient has symptoms with this, then this is definitely something that you want to put in a pacemaker for, even though it's at the level of the sinus node. However, you could have sinoatrial block, also known as sinoauricular block. The sinus node function is normal, but transmission to the atrium is blocked. Remember, you have your sinus node that sits on the outside of the heart, and then you have the AV node, the transitional cells that conduct whatever is going on in the sinus node to the rest of the atrium, and that's where you have your regular conduction. And actually what you see on the EKG is conduction to the atrium. It's not really sinus node conduction, but since we see it in the atrium, then we can assume that the sinus node, of course, is firing. Well, if you have any blockage of that, then that becomes a problem. We typically can't see first degree, right? Because first degree is a equal, delay, in which case, you really wouldn't know because we don't have a lead that sits in on the sinus node. Third degree, sinoatrial block, again, that's something that you would not see. It would just look like a sinus pause. You just wouldn't see any P waves, so the sinus node might be firing, but we wouldn't see it because it wouldn't go through to the atrial node. And so those are patients who sometimes they will come in with either an ectopic atrial rhythm that you can notice on EKG, or they'll come in with just pauses, an injunctional escape rhythm. But you can see the second degree type 1 and type 2. It becomes a little bit difficult because instead of you seeing changes in your PR interval, you have to imagine in your mind that your sinus node is firing, but something is going on here that's not producing atrial depolarization, and so you don't have a P wave. And so what typically happens is you'll see your PP interval slowly decreasing, and then all of a sudden you see a pause. That would be a second degree Winkie block of a sinoatrial block. For the sinoatrial block second degree type 2, in this particular situation, you're going to have a PR interval that's correct, a PP interval that's consistent, but you will have a pause, with this pause being a multiple of your original PP interval. And so that's something that you can definitely look at. For atrioventricular conduction, this is your normal atrioventricular conduction, where your PR interval is typically less than 200 milliseconds. We use the EP study for us to actually look at what's going on in the His-Purkinje system, and what we expect to see is that your His-Purkinje system should have a really short conduction. Your AH interval or your conduction through your AV node could be a little bit longer, but your AH interval plus your HV interval will give you a PR interval on your surface EKG. So sometimes what we see in the surface EKG can actually tell us what's going on, in the EP study without actually having to do that. So for atrioventricular block, that's second degree, it could be pathologic, but then sometimes it could be normal, right? If you have a patient who has sleep apnea, if they have atrial tachycardia, the problem is actually the tachycardia is not actually their conduction system. Sometimes you have inferior wall myocardial infarctions that actually affect the blood supply to the AV node, and of course some drugs can cause it as well. In which case, by changing the condition, sometimes by exercising, by giving atropine, you can actually decide which one is important and what you need to intervene on. So as a rule of thumb, your atrioventricular block, your second degree AV block type 1, typically happens in the AV node, versus your second degree type 2 that usually happens below the level of the AV node, and typically is something that you want to intervene on sooner rather than later. So if you are looking at an EKG and you see group beating, you should be thinking to yourself that this is as a result of, atrioventricular block or second degree AV block, depending on, what it could be. So now going back to some questions, this is an EKG. If you look here, you can kind of see your PR intervals, and then all of a sudden you see pauses. You definitely see that group beating. But can somebody tell me what you consider the diagnosis here to be? And if you can put that in the chat. Okay, somebody said inferior MI. That's correct. But then what else is happening? If you were looking at the conduction for this patient, particularly with these pauses, yes, so somebody said Winkie box, second degree Movitz 1, exactly. The easiest way to look at this is when you see, first of all, when you look at the EKG, remember what I said, when you look at the EKG and you see your RR interval is kind of irregular, right? And it's regularly irregular, right? So you see what we call group bleeding. So these four are going together, these four are going together. Then in your mind, you should be thinking, okay, this is a second degree AV block. Now, what kind of second degree is it? Right? So the relationship between the P wave and the QRS is going to give you an answer. So you have a blocked P wave here, you have a blocked P wave there. If you look at the P wave immediately following the blocked P wave, and you look at the P wave that immediately precedes the blocked P wave, when you look at those, if there's the PR interval there is different, particularly if this one, the one following, is shorter than the one preceding, then that means that that's a second degree type 1. If it's a Mobitz 2, this PR interval and that PR interval would be exactly the same. So this is a Mobitz 1 or Winky block, right? So in this case, does this patient need a pacemaker? Yes or no? So somebody said no, 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 no. So what if I said that this patient, actually they took them to the cath lab and they noticed that the patient had a very small, and this is like going out of the box a little bit, but basically they said, okay, this patient had a very small RCA and had a more dominant, wraparound LAD. Then what? Would you consider that this patient needed a pacemaker or not? I think everybody is still saying no. Everybody said no. Yeah. Thought about it? No. All right. Moving on. What is your diagnosis for this one? Checking EKG, rhythm strip. What would you say this diagnosis is? 2-to-1 AV block, exactly. So as you can see, unlike that first EKG that I showed you, where you had regular QRSs as well, in this particular one, you can see that your PR interval is the same when you consider from here to there to there, and then also there's one intervening one that isn't. So this is 2-to-1 AV block. Now, can you tell if somebody has 2-to-1 AV block? Can you tell if it's a Mobitz 1 or a Mobitz 2? Because a 2-to-1 AV block technically is a second degree AV block, right? So would you be able to tell if it's Mobitz 1 or Mobitz 2? Somebody said Mobitz 2, Mobitz 2, RCA 2. Mobitz 2. So, and somebody was very emphatic in saying, Safety was very emphatic in saying, you cannot tell. And exactly, you can't really tell. Because for you to define whether something is Mobitz 1 or Mobitz 2, you have to be able to see the progression. So you need to see whether it extends or whether it stays the same. And that's impossible to determine if it's a 2-to-1 AV block. So the only thing that you can tell is that it's 2-to-1. Now there are a few things that you can look at to kind of see whether it's Mobitz 1 or Mobitz 2, or whether the block is suprahiscient or infrahiscient. One of which is, looking at what's happening in your QRS. In this particular patient said, does this patient need a pacemaker? Somebody said yes. And it really all depends, right? If you have a QRS width that is normal and it's, your PR of your conducted wave is greater than 30 milliseconds, then you can be rest assured that most likely your block is in the AV node. In which case, you might actually not need to put in a pacemaker. However, if it is lower than that, then you kind of consider that, hey, maybe this block is actually below the level of the AV node, and so in which case this has a high propensity to progress into a complete heart block. So those patients typically will need some. And unfortunately, sometimes they can go from 2-to-1 AV block to actually like a 4-to-1, or a sudden loss of, the escape rhythm, in which case this becomes a really big issue. Now, you want to see also what is their response to exercise, as well as what is their response to a carotid massage, right? So if you give them atropine or you exercise them, and they actually improve conduction, then that means that the block is in the AV node, doesn't really need a pacemaker. If it's below that, or if it worsens conduction, that means that the block is in the His-Purkinje system, and actually that means that you do need a pacemaker. On the opposite end, if you do a carotid massage, and first of all, before anybody does a carotid massage, please make sure that the patient doesn't have any buoys. We don't want to give anybody a stroke, because you really do have to massage that and kind of be uncomfortable with it for you to actually see the effect. And if the patient, you massage the carotids and it actually improves conduction, that actually shows that the patient will have block in the His-Purkinje system. These are the patients who sometimes we suspected and will actually tell you, hey, just give the patient a beta blocker. Trust me, it's going to work. And most people don't do it because they don't believe us, because, we're crazy. But if you slow down conduction to the AV node, that gives the His-Purkinje system a chance to recover, and that actually will improve conduction. So that will actually tell you that, hey, we actually need to put in a pacemaker because this patient has block in the His-Purkinje system. Retrograde conduction, that's something that's a little bit more technical. So when we're kind of figuring out, okay, for sinus node dysfunction, whether the patient needs a pacemaker or not, class 1 is if they have symptomatic bradycardia, sinus pauses. Basically, if they have symptoms, they definitely need a pacemaker. If you're class 2A, if they have sinus node dysfunction with a heart rate less than 40, with a history of symptoms or syncope of unknown origin, then you should put in a pacemaker. That's a 2A. 2B, if they have minimal symptoms but have a resting heart rate less than 40 beats per minute, that is a 2B indication for placement of a pacemaker. Class 3, asymptomatic patients. So if the patient, no matter what they have, they're asymptomatic for sinus node dysfunction, then you don't have to put in a pacemaker for those patients. For AV node, class 1, third degree or second degree with symptoms, of course, documented pauses that are greater than 3 seconds. Even if you have if you have asymptomatic third degree or advanced second degree AV block and pauses that are greater than 5 seconds, or asymptomatic third degree advanced second degree with documented pauses greater than 3 seconds, all of these, are an exception to the symptomatic rule, so they can be asymptomatic. Now, of course, if you've ablated the AV junction, definitely do that. If you have post-op AV block that's not going to resolve, you definitely don't want the patient to die of, AV block after having surgery. And then, of course, if they have second or third degree AV block during exercise with no risk of ischemia. And then these are the ones if they have neuromuscular diseases, second degree AV block with symptoms, asymptomatic third degree block with a heart rate that's greater than 40, but LV dysfunction, cardiomyopathy. Those patients are all class 1 for placement of pacemaker. For 2A, if you have persistent AV block, so third degree, basically put in a pacemaker if you see one. If you have infrahysian block on an EP study, so if that HV interval is long, then you definitely want to put a pacemaker there. And then if they have a type 2 second degree, but basically a narrow QRS, then, that's a class 2A, but if it's wide, then it becomes a class 1 indication. 2B, drug use or toxicity. If you expect the, effects to continue even after the drug is withdrawn, definitely put in a pacemaker there. And then your class 3 is, definitely first degree AV block, particularly if it's asymptomatic. There's sometimes that you have symptomatic third degree AV block. So basically the person has such a long PR interval that when the atrium is contracting, it's contracting against a closed AV valve, like a mitral valve or or tricuspid valve, and that can cause symptoms for the patient, similar to a pacemaker syndrome. If you see that, then maybe, it's necessary for you to put in a pacemaker. But if the patient is asymptomatic, then you don't have to. And of course, if you're asymptomatic with your second degree type 1, if you think it's going to be super Hessian, or if you have cases that are expected to resolve, such as increased vagal tone, patients who have sleep apnea, that you see that there. Of course, if you diagnose the patient with Lyme disease, or if they have any type of drug toxicity, then you don't want to put a pacemaker there. The most interesting situation is when patients will have symptomatic bradycardia that's out of proportion to what you would expect, but the drug that they're on is a beta blocker. Well, if they're on a beta blocker because of some other reason that you can take the beta blocker off, then they don't need to have a pacemaker placed. However, if they have heart failure, and the difference between, putting a pacemaker and putting in an ICD and the patient having heart failure, continued heart failure as a result, is, the use of the beta blocker, then you definitely will want to place the beta blocker. Same thing goes in for atrial fibrillation. If you take off the beta blocker and the patient goes into AFib with RVR, but you need the beta blocker, but when you give the patient the beta blocker, they actually get really symptomatic, then that would be somebody that you would want to put in a pacemaker as a result. So in conclusion, for the patient selection piece, first degree AV block, if they have symptoms, then sure. If there's no symptoms, then no. Second degree, most of the time, yes, particularly if they have symptoms. And third degree, definitely yes for a pacemaker if they have symptoms. Okay. Now, somebody had asked a little bit earlier, or going back to some of the questions that I asked initially, what other information do you need from a patient who has clear indications for a pacemaker? Why would we ask to get an echo? Well, one of the things that you want to consider is if the patient has heart failure, because if the patient does have heart failure, then you want to see why they have heart failure, and then you might actually be indicated to place an ICD. You don't want to put in a pacemaker when the patient needs an ICD. And worst case scenario, if the patient can't afford an ICD, then you might actually need to place a biventricular pacemaker. Just so that you can help with the cardiac resynchronization therapy. And because those patients, if they have heart failure, they'll actually get much worse if they have a high degree of pacing. So that's one of the things that you should consider. Now, a solution to placement of, a biventricular pacer, since that is an extra lead and is more expensive. So a solution in resource for environments might actually be the left bundle lead that Dr. Edafe actually placed by himself, learned it a few months ago, and placed by himself, I think yesterday. This is an example of his, This is an example of his procedure. And as you can see, the lead is going, so that's the RA lead, and then the one going to the ventricle is actually pointing towards the septum. This is an AP view that he gave us. And then this is the EKG, and you can kind of see how narrow it really looks. This is not a typical paced QRS. And you might tell yourself, well, this doesn't look to be paced at all, but you can kind of see the transition from her native to the pace QRS. Most likely the programming was going to be, like, she wasn't going to pace anyway, but at the very least, if she was going to pace, you would see that she would have a normal QRS. And that is all I have. So if you have any questions, you can go to see us on our website. The QR code is for our website. I would like to thank all these folks who have, helped with the, spread and accessibility of pacemakers all over Sub-Saharan Africa. And if you have any questions, please raise your hand. Thank you.
Fantastic. Yeah, really, I appreciate that presentation. We all appreciate that presentation, Dr. Kerr. Looks like Dr. Dafe is raising his hand to speak as well. So, Dr. Dafe, sir.
Yeah, thank you very much. Dr. Joma, thank you so much. Very well educated and excellent presentation, man. I really enjoyed it. Even though my network at a point in time was off and on, So, but very great presentation. I wanted to ask, man, can you throw more light on mobile cath labs? Because I found out that we don't have that significant number in the sub-Saharan Africa compared to what is obtainable in India.
Oh, you mean like mobile cath labs that you can put on a bus?
Yes. You know, when you were comparing, you
Yes.
compare the CM and the cath lab.
Yes.
So I was also thinking, okay, what of a mobile cath lab and a CM?
So the
is
mobile
there
cath lab
any
is,
issue we can look at it?
yeah, the mobile cath lab is actually a cath lab. So it basically, so the mobile cath lab is basically similar to a cath lab. So the cost of it can be high. It's definitely much higher than a CR. And then you have the same, limitations with regards to lead shielding, etc. But the good thing about a mobile cath lab is that you can go from place to place, right? So you're not limited by location. So that's one thing.
Okay.
Actually, like here, we've used mobile cath labs before. Basically, I think we had used it in a couple of hospitals where something happened with the actual room in the cath lab, and then they got a mobile cath lab and would basically take patients in and bring patients out. So it's pretty much, when you walk into the mobile cath lab, it actually looks like a regular cath lab. It's a little bit smaller on the smaller side, but it has an II and the high power and all of that, and you're able to do coronary angiograms and able to put in all sorts of pacers. So yeah, it's definitely an option if we have a sponsor to buy us one. Then you can you can definitely take it from place to place for sure.
Yeah, thank you, man.
Any other questions? So with this particular patient, the one that we talked about, particularly her being a young lady, or a young person, you have some considerations that you have to think about when you are figuring out what kind of device that you want to place. First thing is, if you can have a device placed that does not give this patient heart failure, that would be the best thing. And left bundle is kind of coming out with that. We call it conduction system pacing. If you have left bundle pacing for right now, there's no limitation or there's no recommendation that, it's only patients who have heart failure. So CRT, you can only do it, or it's only indicated in patients who have a demonstrated ejection fraction that's less than 50%. For left bundle pacing, you can do it in everyone. And so sometimes folks will say, you know what, I'd rather do left bundle pacing than do, a regular pacer in a patient, even if they don't have a high degree of pacing, because I don't know what's going to happen in the future. And then if they do have a high degree of pacing, even though their ejection fraction is normal, maybe they could be one of those 20% of people who will actually end up having a decreased ejection fraction as a result of a high degree of pacing. And so placement of a left bundle pacer or conduction system pacing could actually be protective in those kinds of patients. And so that's the reason why sometimes we end up doing that in certain patients. So somebody wanted to speak, Dr. Gandia?
Yes, thank you, Dr. Ijoma. That was a very nice presentation. Do you hear me?
Yes, we can hear you.
Yes.
Thank you.
I just wanted to compliment on the conductive system pacing. Actually, I quite agree with you that the current practice in the other centers, they have just decided almost all patients who are coming with the indications for pacemaker, excluding the CRT, they will just go to conductive system pacing, that is left bundle branch area pacing. Yeah, maybe another point to add is that you don't need all the proper instrument, because you need the left bundle branch area specific read, and also the catheter that can the select site catheter that can enable you to go to the septum. But it is quite possible if you have the select site catheter, just to use the ordinary lead, you can that can aid you to go to the septum and use the normal pacemaker lead that we are using, and you can get almost the same results.
And I think
because
it really
we've seen a lot of patients, once you put, apical pacing, there is a high chance that they are getting to get complication, including atrial fibrillation.
Mm-hmm.
Yes.
And so I agree with you for sure. I think that, you definitely need for the select secure, because that's a very specific lead. We should be careful about the lead that you put in the left bundle area, because what is ending up happening, right, is that you are screwing in the lead into the septum. So you're going to have a hinge point at the lead that could result in fracture, right, in the future. And so that's the reason why the actual lead, the 3830 that Medtronic produced, it's been tested to make sure that that doesn't happen. And I believe the new ones that are indicated for that now, like the Tendril, the 2088 for Abbott, and I know there's a Biotronic lead that's specific for that. I think that that's the reason why you want to use those specifically indicated leads for left bundle pacing, and not just any lead, because not all the leads have been tested and have been gone through that integrity where you're sure that that hinge point will not result in a fracture. And remember, you're also screwing it into the septum, so extracting it is going to be a whole nother ball of wax. So you definitely want to make sure that you're being careful and definitely using only the indicated tools. And some of them, like I wouldn't use 5096 for, was it a 5046? A 5076, right? I wouldn't use a 5076 or 4076, which is a Medtronic pacing lead. I wouldn't use that for the left bundle area, just because they themselves have not cleared it for left bundle pacing. So even though technically you could, I wouldn't. And somebody asked a question about, whether I can explain more why some 2-to-1 AV block doesn't need a pacemaker. Remember, 2-to-1 AV block is a second degree AV block. So if you have a second degree AV block that has 2-to-1, but the 2-to-1 is in certain conditions. So for instance, if the patient was on a beta blocker, or was on clonidine, or was, and it basically shows that this is in the AV node. So you did maneuvers that proved that it was in the AV node. So you did a carotid massage and conduction decreased, or you gave atropine or exercise and conduction improved. Then that meant that, okay, it's in the AV node, most likely it's going to recover. So those patients might not need a pacemaker. Now, it doesn't mean that you shouldn't observe the patient. For sure, that is definitely something that you should do. But you should consider that those patients, especially if they're asymptomatic, those patients might not need a pacer. So really, at the top of the indications for patients who need a pacemaker, it's symptoms. So any patient who comes to you says, hey, I fainted, I was dizzy, I broke my leg because, I don't know, I fainted and I didn't know why, and then you figure out that they have some sort of atrioventricular block, definitely needs a pacemaker. But those patients who are asymptomatic, that's when you start teasing things through. So if you have asymptomatic patients and they have, third degree AV block, they still indicate it for a pacer. If they have second degree type 2, so that means that their QRS is wide or their PR interval is short, and you basically think that, hey, this block is infrahisian, which basically means that it's below the level of the AV node, most likely they'll need a pacemaker. However, if it's nodal, then it's most likely recoverable, and so you might not need a pacer. And that's pretty much the way that we typically do things. And then for the sinus node, typically if it's above, the sinus rate is above 40 beats a minute, most likely, and they're asymptomatic, most likely they won't need a pacer. If it's below that, or if they're symptomatic, if they don't have what we call chronotropic competence, which basically means that they're not able to raise their heart rate with, activity, then you are probably going to need a pacemaker. And Rafaela Atassi, Dr. Atassi, you raised up your hand.
Thank you very much for the nice presentation. You hear me, guys?
Yes, we do.
Okay. I just want to add a note to the last questionnaire. The person they're talking about pacing in the septum. And I urge the new implanters to try to avoid the right ventricular apex if they can. It does not have to be left bundle pacing. It does not have to be, his bundle pacing. But please avoid pacing in the RV apex. Studies have been there for years now that talks about that place. The apex could be, associated with cardiomyopathies, with more atrial fibrillation, more perforation, all of that stuff. So early in your career, when you start learning how to implant, if you start at this point avoiding the apex and keep avoiding the apex, the perfect position is, like you said, it's the left bundle, the conduction system. But even if you're, just avoid the apex, it still works. Pacing the septum still probably much better than pacing the apex. That's the only observation I have.
Thank you. Dr. Gandia?
Yes, I quite agree with him. That's the concept that I was trying to explain before. That you are trying to use even the regular lead to go to the septum, because I know you might not get the, exactly the results that you would have obtained if you are having a special lead, but it is giving some, pacing closer to the conductive system. You at least can get a narrow QRS complex, but still there are other people they think that even if you go to septum and you don't get exactly the narrow QRS complex, probably you are having almost the same pacing the muscles, because the problem with the apical pacing is that you are creating a left bundle branch block. And with that means you are causing desynchrony and therefore increasing the left ventricular, left atrial pressures that are actually lead to electrical remodeling within the atrium, and this actually predisposes to heart failure, AF, and also leading to all complications in the patient. So, yeah, I think there are many schools, but if you ask me, I think because we are talking especially those areas that are resource limited, then I will try to use what I have. The normal is to go to the septum when they are sure, see what the patient, expect the patient is going to feel better as compared if I put the lead in the RV apex. That's the idea behind.
I guess, because when we say, there's always a struggle, right? When you are in a resource limited environment to do what is best, but you also don't want to do harm. And so, when we talk about, using what is available, I guess my point was, you have to be sure that the lead that you're using is going to be able to do the job that you want it to do. Because in the short term, you might be able to help, but you don't want a situation where you cause harm in the long term, particularly if the patient is younger, right? So and then also, we love left bundle now, but there's still a lot to be learned from left bundle, and we still have a lot to discover. There still has to be a lot of follow-up. I kind of want to urge us to take caution. For instance, a long time ago, we everybody was going to the HIS, and now almost nobody goes to the HIS anymore. Just mainly because of other considerations. Not that the HIS placement was not a good idea, but eventually it was something that didn't actually stand the test of time. And who knows, the same thing might happen with left bundle, and we might be doing something else, a few years later. So the only thing that we can do for right now is, make sure that we're using the tools the way that they're supposed to be used, and reaching out to, foundations, like ours. There's the Melvin Scheinman Foundation, there's My Heart, Your Heart, there's Dr. Joel Dunning. If the specific leads that you need that are not available, then maybe we can make sure that they're available so that at least you're using the indicated tools for the indications that you need them to, and you're not having to make do, and in the future that causes harm. So, well, thank you, everyone. Oh, I'm sorry, did you have something else to say?
No, I just want to make a point. I agree with the last speaker very much so. It's not using the available technology in the left bundle to pace the conduction system. It's just, my point is avoid the apex. That's what I'm trying to say.
Yes.
Use whatever technology you have, the leads you have, but avoid the apex. You know, it doesn't cost the same leads, the same techniques, same everything. Just stay away from the apex. Thank you very much. I appreciate the chance.
Thank you.
But the last comment, Dr. Joma, what's the cost difference between the regular lead and this new? I find it's like the same price. So maybe it's just a matter of ordering the proper equipment, because I don't think if they make a huge difference in terms of purchase.
Yeah, and that's probably it. It's just kind of making sure that you're ordering the same thing, for sure.
I mean, there is the introducer. There is the introducer. I don't know how much it costs. And the lead itself probably is a little bit more expensive than the traditional big leads here in the States. I mean, in Africa and in other parts of the world, you know, $100 here, $100 there adds up significantly.
Mm-hmm.
Yeah, I will say the left bundle sheet is much harder to come by on the continent itself. You know, as more people show interest and as there's more implanters, I think you'll see it proliferate.
But I'm trying to think in this direction. Okay, maybe the price, let's say it's not very huge, significant, but you avoid purchasing the right tool, then you get into heart failure because of you're having regular lead, and you need the CRT that is too much expensive as compared. I think maybe sometimes we need to think ahead of time what's going to happen, because you are avoiding this, but you are creating a more problem, then you get more costs to incur.
I mean,
like
honestly,
your way of thinking. Yes.
Yeah.
Yes.
I mean, honestly, like, these are discussions that definitely need to be had on a wider level, because unfortunately, what is happening here is that we have small hospitals, like, you're making decisions based off of like a small population, right? Versus if a lot of this was being supported, if there were insurance plans and things like that, then you could make population-based decisions that would help your local purchasing power. So I think that the problem here is that maybe sometimes because you're buying for your hospital and you don't have the strength of collective bargaining, then things end up being more expensive when they don't necessarily have to be. But those are definitely discussions that have to be had at a huge forum with the stakeholders, and on the one hand, and the folks in industry on the other, so that they make these technologies available at a fair cost, at a fair market cost, considering the price per person or the healthcare dollars that are available in each different country. So, but thank you so much, everyone, for such a great discussion. AJ, I didn't know if you had anything else to add.
No, yeah, thank you, Dr. Joma, for going to that. I think you did a really good job of laying out what's needed from a holistic perspective. It's not just the resources, but it's the human resources as well. It's the knowledge, it's the support staff, and it all kind of comes together. So, we really kind of got into the weeds here, talking about that bundle, more complex stuff, when we started off on pacemakers. But I think that shows the level of sophistication in many of these programs around the continent. So if you are new to this and you're trying to start a pacemaker program, we highly recommend to leverage these relationships. Reach out to us, reach out to our foundations, reach out to the individual organizations that it's called, And, people are here to help and support and talk you through the process. And we don't have to make the same mistakes. Again, we can all kind of learn from each other's experience. That's what we're all here for as a community. So really, I appreciate it. I appreciate everyone being on the call today.
All right. Thank you. Bye.
So just some housekeeping. So next week we'll pick up the EKG conference again shortly. Global Fix for our hotel. So I appreciate everyone being on today. See you next Sunday.
Bye.
Thank you very much.
Bye.
Thank you.
Dum 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 tururu, dum 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 tururu, tururu dum 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 tururu, tururu. Dum 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 tururu, dum 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 tururu, tururu dum 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 tururu, tururu. The same qualities foundation. Tunakuletea msimu wa 6 wa marathon na kusherehekea miaka 10 tangu kuanzisha. Wote upasuaji wa watoto wenye midomo wazi itakayofanyika jijini Arusha. Hatua moja, tabasamu moja. 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 Tunasema tunawakaribisha.